The broadcast is now starting. All attendees are in listen-only mode.
Good evening and good afternoon or good morning for some of you. Welcome to the webinar on the how to show how well a fracture liaison service works. My name is Masaki Fujita. I am the Capture the Fracture Global Program Coordinator at IOF in Switzerland. It is my pleasure to run this webinar today with our speaker, Professor Qasim Jawaid. Professor Jawaid is an associate professor at the Nuffield Center of Orthopedics, Rheumatology, and Musculoskeletal Sciences at University of Oxford. He is also an expert on secondary fracture prevention and implementing FLS, and is the current co-chair of the CTF Steering Committee. Before I begin, I'd like to inform all attendees that you are automatically muted. So if you have any questions, please feel free to type your questions into the question box. They will be collected throughout the webinar, and I will voice them towards you towards the end of the webinar. Now on to you, Qasim, when you're ready.
Okay, I'm ready. I assume everyone can see my screen. Is that right,
Yes.
Masaki?
Yes, perfect.
Great. So welcome, everyone. It's really my pleasure to share with you our thinking on how to measure how well a fracture liaison service works. And this presentation is for people who've got an established FLS, who've been doing it for a decade or more, those who have just started, or those who are thinking of starting and often have the question of what data do I need to record? How do I know I'm really working? And more importantly, how do I show my payers that I'm working? So these are my disclosures. This is a non-sponsored symposium. So just some introductions. Capture the Fracture is a program of work through the International Osteoporosis Foundation. It's been running now for over 5 years, and the mission of the program is to use fracture liaison services to close the care gap. So everyone, including this woman in the picture here, after she has her first fracture, gets treatment to prevent the second fracture. To do this, we have 4 aims. We aim to be the global voice for fracture liaison services and Capture the Fracture program, drive national and international policy, and what we're really talking about today is about ensuring quality and providing support, and particularly around FLS sustainability and getting started. I'm a small cog in quite an esteemed team of advisors from across the world. I co-chair with Christina Ackerson, an orthopedic surgeon from Sweden. Cyrus Cooper is the president of the IOF, and Serge Ferrari is the chair of the CSAs. I'm really grateful for the inputs from Thierry, Willem, Stefan, Paul Mitchell, and Donica, who really do the nuts and bolts and help us get the CTF program running as fast as it has been. So some introductory slides. Fracture liaison service and secondary fracture prevention falls within the care pathway for fragility and falls prevention. At the top, we have hip fractures, and we know that better hip fracture care through orthogeriatrics, time to surgery, and rehabilitation improves outcomes, reduces mortality, and also is cheaper for the healthcare system. And then in the bottom, we have healthy aging, life course approaches to sarcopenia, and then above that, high risk primary prevention. This is about screening in the population and reducing falls risk. And secondary fracture prevention for fracture liaison service really is the amber below the red of fractures. And in a very simple, approach, the rationale for this is that if you look at hip fractures, we estimate about 50% of them come from those top 2 tiers of the pyramid. And that comprises 16% of the general population. So in terms of priority for delivery for a healthcare system, it really does focus minds on hip fractures and secondary fracture prevention. And we've worked out now over the years what it takes to deliver a good secondary fracture prevention. And on the left, we have the healthcare system. It's got to identify patients at risk, systematic investigation and risk assessment, and then tailored appropriate treatment initiation, which often involves working with primary care. And then critically important, ongoing treatment and fracture monitoring. And that's really been the sea change that we've seen over the last few years. Originally, when set up by Alistair McClellan and Stephen Gallagher in Glasgow in the late 1990s, the focus was on the first three of identification, investigation, initiation. And there's been a real realization that unless you add the monitoring to this FLS chain, you probably won't realize the reductions in fracture rates, which then lead to reduced secondary care admissions and care home admissions. And it's only once you've done that, you can actually realize the healthcare savings to actually pay for the FLS service. So what we know, what is an FLS? It's not education, it's not leaflets, and it's probably not referring or asking others to do extra work. Most healthcare systems that I've worked with are already at capacity, and relying on someone else to deliver part of this chain opens up fracture liaison services to becoming ineffective. So most FLSs that are now being developed are a small core specialist service, and it's been a real shift from coordination to actually delivering the pathway. It's usually led by a champion, which can be a doctor or can be a specialist nurse, who then works with other specialist nurses and administrators to deliver the pathway. They arrange the DEX and laboratory tests and any treatment and ongoing referrals and monitoring. But even delivering this offers lots of different choices each FLS has to decide on based on their local healthcare setting. And I've listed a few of them here, and these decisions are important because they affect how much time it takes, and time equals nursing and staff time, which equals funding for the FLS. So these have economic impacts. And the choices for identification can be face-to-face or using lists or clinic letters or other referral pathways across multiple disciplines. How do you investigate patients? Do you invite them to a separate FLS appointment, or do you try and do as much as you can whilst they're actually in the hospital being diagnosed for their fracture? Initiation of treatment is basically, do you recommend or do you actually dispense from your hospital? And that will depend on local reimbursement systems. What's the balance of oral therapies versus injectables and the affordability of therapy? And then on to monitoring. Do you do this by telephone, by letter, by email? Do you ask people to come back to clinic? Who's in that clinic? Is it a doctor? Is it a nurse? Do you simply use primary care prescribing records, as some healthcare systems have? And here we get into the issue of ownership of the patient and access to the patient once they've left the secondary care or primary care hub, which identified the fracture. And often an FLS is faced with quite a wide range of options and need to have a system to make sure that whichever option they choose is the most efficient. Because the real challenge is overcoming the barriers. And we can divide these barriers into system barriers, clinical barriers with your clinical colleagues, and patient level barriers. And they really fall into the same categories at whichever level you look at it. There's low prioritization usually of secondary fracture prevention. There's a need for sustainable funding for a service if it's to be effective. And eventually reimbursement is the most critical issue. Who will fund the ongoing delivery of the fracture liaison service? So some years ago now, and you've probably all seen this, and this is freely available on the web in many languages. You can see the team at the IOF Capture the Fracture has created the best practice framework, and this for the first time set out an internationally endorsed standards at the facilities level for an FLS. It invited guidance on how to improve, and critically created an audit tool where we could measure quality of different services. And credit to the work of Masaki and others in the CSA. We now have over almost 270 FLSs across 38 countries and 6 continents, and you can see the geographic spread. And over the years, more and more FLSs have joined, and we think we've got about 30 to 40% of the FLSs in some countries, whereas in other countries we have low numbers. And when you look at this on this graph, or picture of the world, the countries are color-coded depending on how many FLSs they have per country. So in red, in Iceland and in Argentina, we have 1 FLS on the map, also in Japan. In orange, we have 2 FLSs. In purple, we have 5 to 9 FLSs. And in blue, we have 10 to 20 FLSs. Finally, in a few countries, we are actually managing to get quite widespread FLS interventions implemented. And here there are more than 20 FLSs per country. And the aim of the Capture the Fracture program is to turn the whole world green. It doesn't matter where you live, there are a number of FLSs embedded within the healthcare system on a sustainable fashion. To do this, we really need to be able to demonstrate, depending on your healthcare system, that your FLS is actually working. And currently, there is no set of standards at the patient level to show an FLS is working. And those of you familiar with the literature will know there are a number of publications now that are able to demonstrate reductions in refracture, reductions in overall hip fracture rates, reductions in mortality by implementation of an FLS. Other outcomes that other services have used include uptake of DEXA, uptake of treatment, and treatment adherence. We at the IOF were having a number of about what is the minimum clinical data set we can record in an FLS, and I know there are lots of different. It's not clinically related, and actually is based on the concept that quality improvement is key to the success of an FLS. And that's because a very important concept that the healthcare system in which you put in your FLS is constantly changing. Patients are getting older, orthopedic practice is changing, and the FLS needs to adapt to this and needs a way to measure itself to make sure it's still delivering on its key outcomes. So building on the work from the United Kingdom Fracture Liaison Service database, the Capture the Fracture Advisory Group has now worked to generate 11 key performance indicators, which I've listed here. And in the rest of the presentation, we will then go through each of these. And what I'm going to do now is go through each of them, and with each one, explain to you why we've chosen these specific indicators to help you understand why they are relevant, and hopefully be able to implement them into your FLS, whether it's an existing FLS or a new FLS. Controversially, I'm going to start with the second one and leave the first one till the end. So identification is the first one, and this is probably the first hurdle any FLS poses and has to address, is how do you find all the patients who you should be finding? And we know that patients who don't attend an FLS appointment are likely to have a higher comorbidity profile, more likely to be older and frailer, and therefore have a higher refracture risk. And really good evidence is coming out now that unless you can find as many patients as you can within your FLS at high risk, the impact of your FLS in reducing refractures will be blunted. So this is an indicator. The numerator is quite easy. It's the number of patients you've submitted in the last month or in the last year. We have usually it's the last year. The denominator is challenging, and that's how many an FLS should see. There are different ways to calculate this, and a very easy way that many centers have used, and it's probably an underestimate when you think of the current rate of vertebral fractures, but it's 5 times the number of hip fractures. So if your hospital sees 500 hip fractures, then the total number of patients that your FLS should be seeing in that year should be 2,500, and that includes the hip fractures. And we've sort of come with a grading system that if you're seeing less than 50% of the expected caseload, that's red, up to 75% is orange, and green is more than 75%. And then we're also suggesting you can stratify your key performance indicator by looking at those under and over 75 to see where any gap is. Are you missing older patients or are you missing younger patients? And roughly 75 is a split of your FLS population, 50-50. This is important. So a really nice paper looking at an FLS study in Australia. So they had, just to show you how you have to be very careful about this, is that you set up a very effective FLS program that picks up patients with a major fracture, and already you can see that to get from 551, before you even started to go through the pathway of testing people, getting them to come up from their DEXA scan, started doing more adherence, you've already lost half your population. 32% were deemed ineligible. Of course, the ones who died you can't really do anything about, but the number of high-level care facilities, these are your highest risk patients, some would say, and should be the real focus of the FLS. And then 25% declined to participate. And really, this is a critical issue of mindset, in that we have to change the mindset of patients, and actually secondary fracture prevention is part of the trauma experience. And really, you wouldn't ask a patient's broken an arm if they were going to have blood tests. This is just part of the assessment of their hospital visit. The second key performance indicators of ground spine fractures. We know spine fractures are underreported and poorly managed, and they're a big challenge for FLSs. So usually we advise that if you're setting up an FLS, leave the spine fractures to last, because they require a separate system for identification and have certain different characteristics to other fracture types. And it's easier to get the non-spine fracture pathway sorted out first and build on that, rather than to start with spine fractures and then go to the non-spine. This is an easy indicator to calculate. It's the number of patients with a spine fracture as their index fracture, and the denominator is all patients submitted. You can stratify then by those found by clinical pathways or by radiological methods, either through VFA or opportunistic fracture identification. Just a note, it's very tempting to change the denominator to the number of eligible scans, as you could argue that if one center doesn't do much spinal imaging, then that might affect how many spine fracture patients they can find, which is an important and valid point. However, it's quite difficult to count the number of scans, because some include CT scans, MRI scans, PET scans, and for some FLSs, they may be drawing patients from a number of hospitals, and it was thought to be challenging to get this data. So we've kept the numerator as the number of patients with a spine fracture, and the denominator, the number of patients submitted overall. And just to highlight this again, although the spine fractures can be the hardest to find, spine fractures are the easiest fracture to prevent. Of all the treatments that we have, look at different fracture sites, it's a spine fracture that shows the greatest reduction in risk with pharmacotherapy. And against this, we know that 40% of moderate severe fractures aren't even reported, which challenges models where you're just using a secondary review of all the radiology reports to find the fractures. And we know that over 80% of those that have a fracture aren't recommended osteoporosis checks. So this is the reason we put spine fractures as a separate identification performance indicator. The fourth indicator is about, and the fifth indicator is about timing. And this is about the timing from bone assessment to within 12 weeks. And this really highlights the fact that refractures happen rapidly. Up to 50% of refractures in the spine happen in the first 2 years, and so we have to act fast. And so the numerator is a number of patients assessed within 12 weeks from the time of fracture diagnosis. And that's quite challenging for some centers, but really if we want to really prevent those imminent fractures, we have to get on with assessment quickly and design systems that can do that. And the denominator is all patients submitted. So in this chart, we have nice data from major fractures attending a trauma center and followed up. And you can see by 24 months, 15% of the women, just under 10% of the men had refractured, emphasizing again the need to act quickly after a fracture. Not all centers have access to DEXA, but for those that do, we need to make sure the access to DEXA isn't an issue that's blocking the performance of an FLS. So this is how many people from time of fracture have a DEXA within 12 weeks. And the denominator is all patients. In some healthcare systems, patients at a certain age threshold do not need a DEXA for reimbursement of their medication. And to recognize this, we've added a stratification option here for less than or more than 75 years. And it's hopefully with this quality improvement indicator, we can actually improve access to this important risk stratification tool. The sixth indicator is about falls. Falls is an integral part of fracture reduction. There are a number of trials that are coming out showing that good falls interventions are adhered to can reduce falls. I recognize this weaker data showing reduction in fractures, but it makes sense that if you've got a patient falling and who is fracturing, to address both the falls component and the fracture component. And this is a very simple indicator. It's the number of patients who've had any type of falls assessment or been referred for a falls assessment or already under a falls pathway, divided by the number of patients submitted. Again, a stratification is recommended to help you understand, because traditionally falls assessments have been inappropriately limited to those aged over 60 or over 75. So we're now on to the seventh key performance indicator, and this is the real critical one. This is about bone therapy recommended. And this is important because we have to put into place risk assessment and systematic assessment of refracture risk and also therapy appropriateness to make sure we prescribe enough high-risk patients. We're fully aware of the published care gap, and that if we have a decision to treat or not to treat, we should probably treat, because when one stands back and looks at the international data, we are generally under-treating high-risk patients. And this is simply a numerator of the number of patients with a bone treatment recommendation. So this does not include calcium vitamin D. This is bone-specific therapy, and the denominator is all patients submitted. Again, a stratification by age. And you know, if you're getting low numbers of people being recommended treatment, then this may reflect that your FLS is missing enough high-risk patients. We're not quite sure what the real bone therapy rate should be for an FLS, but it's coming out at somewhere between overall 40 to 50%, but I fully recognize this is a bimodal distribution, so there's a lower rate of prescribing those aged under 75 compared to those aged over 75, and this often reflects. So here's a nice study from, I think from the States, where they actually integrated post-hip fracture care. So everybody got bone protection therapy as part of their hip fracture pathway. You know, relatively small numbers, 57 patients with a hip fracture. Many hospitals see 10 times this amount in a year. But if you look, I mean, most people would argue post-hip fracture, nearly everybody should get therapy except those undergoing with severe end-stage renal disease or expected to live less than 6 months. And you can see here, it's very easy to put in rules that actually lead to a low penetration of pharmacotherapy. And here you can see, 11 excluded as low BM vitamin D. Well, actually, that shouldn't be an exclusion. We should be able to put in treatment pathways that address this. And the inpatient team were uncomfortable to prescribe because of borderline labs. Are we really sure this is appropriate when we consider the catastrophic results of another hip fracture on patient outcomes? And this led to only 44% of hip fracture patients receiving treatment, which was fantastic improvement from the 0% they had before, but still room for improvement, I feel, in those patients who are excluded because of lab errors that we could probably push back on. And there's a lot of, so let's just talk about clinical barriers. I mean, ideally, we'd want to have the red and the blue. So how likely you are to treat depends on the perceived risk of fracture. And at a certain threshold, we definitely treat everyone. And below that, we definitely reassure everyone. And this is what patients and payers think happens in the medical world. For those of us who live in the medical world, we know actually there's quite a big green area where there's inconsistent treatment advice between countries, between hospitals, between physicians within the same hospital. And what we really must work on is to make sure that green box is as small as possible within the FLS and between FLSs. We should simplify the pathway so the green inconsistent treatment advice is as small as possible. And this is by addressing mismatches in evidence, mismatches in knowledge, and mismatches in experience. And unfortunately, at present, our way of going around this is by making lots of guidelines. And there's pretty good evidence that guidelines make the green box bigger because people as humans will pick and choose a guideline that fits their own personal approach to risk assessment. So the eighth one is strength and balance classes, and we've done a survey within the CTF, and these are available in most countries in the world. Probably the best evidence of falls reductions, and this is a hard one. It involves FLS as being truly holistic, and the number of patients initiating a strength and balance class within 26 weeks of the fracture diagnosis date, divided by the number who had any type of falls assessment. So this is a different denominator than we're usually used to. And again, we've asked for a stratification by age. And we recognize this as aspirational, but think this is a useful driver to drive improvement in falls prevention classes around the world and in the different countries. So at least they're used to reporting data and having some sort of quality improvement. Well, the last three indicators are around follow-up. We know historically that delegating follow-up to primary care or other institutions results in poor adherence. And without adherence to therapy, you cannot achieve fracture reduction. And this has been a very important realization. The numerator is a number of patients who are able to be followed up within 26 weeks of the diagnosis of fracture, and the denominator is all of those with a treatment recommendation referred for treatment. And maybe here you want to stratify by fracture type rather than age, as there may be differences in how hip fracture patients are followed up versus non-hip fracture patients. The penultimate key performance indicator is bone therapy initiation. Again, refractures happen fast. We need to start bone therapy fast. So at least within 6 months of the first index fracture, patients should have started or still be continuing bone-specific therapy. We haven't defined how to measure this. It can be through patient self-report, clinical review, or prescription data. At present, the care gap is probably so large, even if we did this, would be a substantial improvement in patient care. And then the finals of this run of performance indicators is the ultimate indicator. Was the patient still taking bone therapy 52 weeks after the index fracture? This is the hardest one to record because of its duration. time gap from the contact from the FLS, which makes long-term follow-up difficult, but probably it's the only one that really matters. If you can't get people on treatment and staying on treatment by 52 weeks, then it's unlikely to be biologically plausible that your FLS has reduced fractures or had any meaningful impact on refracture rates. So here's some United Kingdom data showing after a hip fracture in survivors, the number of patients who are prescribed a drug after a hip fracture. And you can see each line is a different part of the United Kingdom. So you can see a widespread, so within 4 months, some regions were doing it in 50% of patients only, where some regions were doing it in just over a third. But by 5 years, which we sort of assume would be a reasonable treatment duration with oral bisphosphonates, less than a third of survivors are still on therapy. And this is something that we have to sort of challenge as we go forward. And it's really about focusing on monitoring. That's been a key driver for developing the key performance indicators. So it's built into your business case or your financial model or your FLS model, so it's ready to do this from the get-go, from the start. And one very simple way to do this is at the first initial assessment, you have patients consenting to be contacted for monitoring by the service. And thereby, if there are any challenges to your service, having the moral right or ethical right or access rights to access the patient, you can always point back to actually at the patient level, the patient wants me to contact them. And that usually dissolves any intellectual barriers. Final key performance indicator is the first one, called data completeness. So to be able to be used, you have to complete the performance indicators. So the first performance indicator is actually how many fields, how many patients did you have with less than 20% of fields missing? And the denominator is total number of patients. This is an important one. And we want to get as fewer patients with missing fields as possible. So what happens if you do this experiment in the real world? So we've done this in the United Kingdom. We've actually developed a patient level audit. The results are available online, and there'll be more results coming out in December. But if you list all the FLSs as rows and have on the columns the different key performance indicators, and then you color code them, you can get a very quick dashboard of their activity. Ideally, you want it all green. You don't want red, and orange is sort of room for improvement. And what we found in the UK, we call it, in the in-joke is this is the pizza plot. This is the KPI pizza plot. And you can see many services were doing very well, but actually there was a lot of red everywhere. And this is, if you can see, the further down you go towards monitoring, the more red you get. This is very important, because with this information, the whole point of going to all this effort is that you can then do something with it. It is now without doubt that without measuring how your service performs, you won't actually be able to show that your service is working. And you need to do this because if you don't achieve these key performance indicators, a service may be vulnerable to sustainability and defunding. And this has happened to a number of services in the United Kingdom, probably around the world. And we probably recommend every FLS should be in a KPI program, either locally, regionally, or nationally. In the blue, we have the sort of flow, and we've got FLSs looking at their key performance indicator data, identifying top priorities, upskilling to develop an improvement plan, implementing the service change, then using the same KPIs to measure intended and unintended impacts. In the graph in the green, we've got on the bottom axis amount of effort to make the change, and in the y-axis improvement, and we want to be in the green hash areas. Small changes with big improvement. This might be changing falls assessment, how people are DEXed, What we don't want to do is do lots of effort with little return, which is in the sort of brown hash. How to identify the priorities can be challenged for an FLS. This is when mentoring comes in, either regionally, locally, or through the IOF. There are lots of tools now for basic QI improvement skills, and also learning from other FLSs through a champions network, which we're hoping to set up through the IOF CPF program, whereby FLS coordinators can join a group of active individuals who can share ideas and develop improvement plans and barriers and challenges they've overcome. In pink, I've drawn the main reasons and the main challenges we have. FLSs typically have no time, no funding, no control, and not in their job plan to do this. But I hope I've been able to share with you the real imperative to do this if we're going to deliver the FLSs that are effective at working. Once again, this isn't about a gold standard or a diamond standard or a platinum standard FLS. These are basic key performance indicators for a level 1 FLS to work. And by work, it means reduce fractures. I don't think any FLS is really set up to just improve DEXs or blood testing or identification. Most FLSs I know are set up to reduce fractures. And these KPI address this and give you the basic KPIs you need to achieve to deliver this. We don't think this is a one-stop workshop. This process should be a face-to-face collaboration, maybe using web tools, forums, and groups, and potentially and probably using patients to help address some of the issues around timing and lack of control, and using patient empowerment and self-management to help drive these key performance indicators and their achievement. There's an update where these are draft indicators. We're hoping to get them agreed, and we're waiting for comments from the National Bone Health Alliance in the USA. We've got comments back from the Fragility Fracture Network, and then this will be submitted for publication. It'll also be the final draft we put up on our website and newsletter, and we'll do a survey of its implementation once it's done. So in summary, we've developed KPIs for FLSs to measure if they work, and established, importantly, a baseline to inform quality improvement within FLSs. It is challenging to believe that when you set up an FLS, it won't need to adapt and change as your healthcare system changes, or that you've got everything right from the get-go. And it shows that in the UK, which is regarded as having some of the strongest FLS history, that actually even in the UK, this audit has clearly demonstrated the variation between FLSs and the need for patient-level auditing, as well as the IOF CTF facilities level audit with the stars on the map to really measure the impact of FLSs on patient care. I think this should always be embedded within a quality improvement pathway. And one thing I haven't mentioned is a very important statement. Most changes in healthcare systems are either unhelpful or bad, but you cannot improve without change. And to do this, you need to be able to remeasure your service regularly. And this is why I believe a live audit of data is probably the most efficient way to record the impact of an FLS. That's the end of this form part of the presentation. I work as a small cog in a huge team. I've got a team in Oxford, I've got a rare disease team, I've got my FLS team in the middle, the important capture fracture team with Masaki and others on here. These are the current indicator sets that I'm happy to discuss, and I'm happy to take any questions now using the chat box, and it's over to you, Masaki.
Kasim, thank you very much for your presentation and giving a very neat overview of this important survey. Now, we also appreciate that you've highlighted these key indicators, 11, in detail so that FLS can use and assure the quality of their services at the patient level. Now, we have received a few questions during the webinar, so I would like to move on to the questions and answer session now. And starting with the first question, Kasim, could you elaborate further on the goal, purpose of this survey, and how the results collected from this survey will be used?
So I think the survey has two goals. One is to improve awareness of these key performance indicators, but also help sites and FLSs assess how well they're already collecting this data. The survey will list the indicators, and what it will ask is, are you already collecting them exactly as they're described, which would be great news. Can you collect them using your existing data file? Will you need to modify it, or is it unlikely you'll ever be able to collect them? And that way we'll be able to get an understanding globally on the impact of these key performance indicators and the sort of homework and work we have to do at the IOF to make sure they're globally acceptable and critically implemented.
Yes, thank you for your answer, Kasim. Now, moving on to the next question. This survey highlighted a few or several key performance indicators. Now, which indicators, and I think this is a very good question, which indicators should a FLS focus on first to improve? As you can imagine, we cannot tackle all due to resource limitation.
Yeah, this is a really important question, and the answer depends on how confident you are and on your local healthcare system. And I'll give you the two extreme answers. One is you need to focus on the indicator on identification. If you cannot find the patients, then actually enough patients, then it's unlikely your FLS will ever be successful. If you're just finding low risk, healthy patients, then actually it's unlikely you're going to achieve reduction in refracture. If you're secure that your the FLS model is going to be sustainably funded, I would probably take the start at the end. I would want to make sure in the few patients that I have seen in the FLS, I've achieved therapy adherence at 12 months or 52 weeks. And there's an important reason for that. If you just set up your FLS to identify patients, you haven't really worked out the resource implications to deliver all of the KPI over time. Whereas if you say, okay, I'm just going to look at patients aged over 75 or patients aged under 75 or a specific fracture group, but I'm going to deliver the entire pathway and audit the entire pathway in that patient group, then it's very easy for you to understand the resource and clinical pathways that need to be developed. It's hard work, but once for those 100 or 50 patients, you've gone from the first indicator all the way to the 11th, then actually it's very easy to scale it up. Because then you can say, well, that took half a full-time nurse or 2 nurses and an administrator, this number of scans, this number of letters. For me then to go back to the payer and say, well, for these 100 patients, I've delivered what we think is the basic they need. I now need to deliver it for 1,000 or 3,000. You can then very easily scale it up. So I think it depends on where you are as an FLS. If you have to show that it's feasible, many sites go for identification to make sure you're finding them all. But if you're really interested, if this is going to happen anyway, and you want the most sensible way to deliver it, it will be in a small group try and deliver all of them, and then scale it up to other patient groups. And very controversially, and this is controversial, if you've already got an FLS and you're struggling, maybe you need to see fewer patients with higher quality to make sure you deliver all of these KPIs, and actually go back to your payer and say, you didn't resource me well enough to deliver the full package that I need to make sure I can reduce refractures. I've had to see fewer patients, but I'm seeing them better. This is how much you need to invest.
Thank you, Kasim, for your detailed answer for this question. Now, the next question will be, adding on to what you've said, would it be wise to focus on certain fracture patients in terms of if we go with the option of improving identification of patients, such as improving management of hip fractures and vertebral fractures?
Yeah, so I'm showing you a slide. I think you can start, and every FLS starts small, and it is a stepwise staged implementation. Here I've shown one image, but people can start with different orders. I think it doesn't really matter. The key thing is you've got the service scope worked out. You can actually track the patient from the first indicator to the last to deliver what you need to deliver. And then from that grow out. Traditionally, starting with spine fractures is harder. Starting with inpatients is easier. And starting with hip fractures is easiest because they're in hospital the longest. So if you want to make your life easy, then start with the hip fractures because they're in hospital the longest. Often they've already had most of this done if you've got an orthogeriatric team, and it's simply a matter then of fitting in the treatment recommendations are done and the monitoring, and then you can extend to other inpatients. So that would be, if you want an easy life, that's what we recommend is sort of the case mix stage implementation, but really, it does depend on the hospital that you work in.
Thank you, Kasim, for your answer. I think we have time for one or two more questions. Now, this is going to be more of a general question, but what are the minimum requirements for an FLS to participate in this survey?
Oh, any FLS can participate in the survey. You don't have to be on the map. I mean, ideally, we want as many FLSs on the map as possible, but this is for any FLS. We fully recognize that only about a third of all FLSs are on the map. So 2/3 of FLSs aren't on the map. But the map is just one of our vehicles. We are a non-governmental organization. We're funded with the aim of making sure every patient globally has secondary fracture prevention. To be honest, it doesn't really matter to me if you're on the map or not. I prefer you to be on the map because it improves your access to tools and resources. What we really want is every patient around the world to be having an effective FLS. So that would be my answer. There are so many advantages to being on the map that you get access to the mentoring services, benchmarking data. We've got a special CTF newsletter within the IOF main letter. There's so many advantages, and it's actually become a lot easier now to join, and we can even put you down as a blue star in development. I encourage you to get hold of Masaki, download, get on the map, because then you'll be automatically sent the survey. If you're not on the map, you probably won't get the survey. It'll be harder for you to hear about it. Masaki will have your details if you register for the webinar, but it will be harder for you to get a survey. Another really important outputs that we have, and because of ease, we restrict to those on the map.
Thank you for emphasizing that point, Kasim. I think it's also important, if I can comment, that the purpose of this survey will be to assess the service quality at the patient level. Whereas for those FLS who have completed the BPF questionnaire, they may or may not see that the BPF questionnaire asks similar yet slightly different questions.
Yes, exactly. This survey is about, do you collect the data that you can be, you'll be able to do, as I've said, the database, the local, regional, national database. We keep getting asked, what data do we need to submit to that orange, those orange text on the green line that says, what is that database? The CTF now is mature enough to say, well, these are the sort of indicators you need to be.
Mm-hmm. Also, touching on the next point, we should also emphasize that if an FLS submits or does a survey, their assessment will not affect their initial BPF evaluation. Would you like to comment on that, Kasim?
Oh, yes, completely. So the survey is, do you collect this information? And this is do you collect the key performance indicator data that would make it possible for you to do a patient level audit? The BPT STAR system is a separate audit at the facilities level, and it really is, the best comparison I have is, the the GPT tariff is like, do you have a school? Does it have desks? Does it have children in it? Does it have textbooks? Does it have the right structures to deliver the secondary factor prevention? Separate to that, the key performance indicator is your exam test. And that's your examination. So actually, yeah, you're actually teaching right. What's the quality of the teaching? And that's the real difference. So the two are linked, but they're independent. And there's no relationship between the KPI survey and the star status on the map.
Thank you for distinguishing the two, Kasim, and very interesting analogy that you used there. Now, moving on to our final question. Unfortunately, we're coming to the end of this webinar today. So we have a question from a new FLS, and as you can imagine, they only identify a few patients. Now, would it be worthwhile for them to complete this survey if they have already filled out the BPF questionnaire to join the CTF map, of course? By doing this survey, can they seek and receive better feedback?
Yes, I think it'd be really useful to do the survey, because the survey will help you as a new FLS think, actually, we need to record this data. We need to record the date of fracture. We need to record the date of assessment, the date of DEXA. We need to be able to record when treatment was recommended. We need to record when we first followed up the patient. We need to put in a falls assessment and how many patients are having falls assessment. We need to go to our colleagues and say, do you run something called a strength and balance class? Because if you do, we need to know how many of our patients have started it. And then we need to work out a way which we can figure out and be able to record how patients are actually surviving after they've left the FLS. Are they getting the treatments we've spent all that time getting them onto? And are they staying on those treatments? I think it's very valuable for a new FLS to do this, because it will help you go to the next level and at the patient level really hone down on the sort of data you're collecting.
Thank you, Kasim, very much for answering that final question we had. Now, unfortunately, we are coming to the end of this webinar. So I'd like to take this opportunity to thank everyone for their participation. We really hope that you enjoyed this session. We will post recordings of this webinar along with the slides on the webinar page of the Capture the Fracture website. Now, after this webinar, you'll be asked to fill in a survey. We'd appreciate your input and comments, as we always strive to deliver the webinars that meets your needs. And last but not least, any comments, questions, do not hesitate to send them over to Capture the Fracture at iofbonehealth.org. Now, on that note, again, everybody, thank you very much. And Kasim, thank you very much for your time and for making this lovely presentation.
Not at all. Thank you, everyone. And as Masaki's mentioned, please do get in touch with us with any questions, and look forward to seeing your feedback on the KPI survey soon. Bye-bye.
Bye-bye. Thank you very much. Goodbye.